ان شاء الله كل واحد يشوف الشاشه اذا كان ما فيش
واضح تمام.
كان ممكن لي تكست مسج.
لا واضح تمام. مين يا دكتور تسمع فيه ولا لا؟
نسمع فيكم وخلاص. خلاص اوكي. انتوا سويتش ميوت ذا مايك فور ايفري ون اند ذن اي ويل ستارت.
اوكي انا حندير ميوت. يلا تمام.
يلا بسم الله. في البدايه نحييكم مره ثانيه وان شاء الله يكون الحضور المره هذه احسن من المره الاولى وكلنا مع بعضنا كيف ما كنت نتكلم مع البروفيسور مهدي الخماس ان احنا نتكلم هنا في الغرفه هذه عن علم، يعني التوجهات الاخرى ما دخلناش بها نهائيا، يعني whatever اللي عنده توجه يكون خارج الغرفه هذه وما يقحمش نفسه انه يكون هو الشخص. فان شاء الله انا وعدتكم اني حنكون نبدا في حاجه بدينا بالريكوجنايز سيك تشيلدرن، واليوم نبدا بشيء اللي هو ممكن حتشوفوه كثير جدا في اذا كان تشتغلوا في الاي ار ولا في ولا حد من قاربك سالك عليه ولا اي واحد يعني. it is called febrile convulsion. It's one of the commonest provoked non-epileptic seizures. This is the nutshell about it. I will talk about the febrile convulsions. The objectives, as you can see, is to correct diagnosis febrile seizures, to appropriate manage child presenting with febrile seizure, advise parents and everything. So we're going to start with just a few informations, and I'm sure you have a good knowledge about it. But then I will talk about the meningitis a little bit because it's scared everyone. And then I will give you a case or two scenarios. We'll go over them together at the end of the topic of these sessions. So hopefully we will have 14. I think I will give myself 50 minutes and then 10 minutes questions. So that's hopefully I will achieve this objective at the end of the my talk. Please write down your questions if you can. So in general, we're just going to give a little bit about the risk of, because we're going to cover epilepsy in the next 5 lectures, hopefully, in children. And then we move to the next one, is the risk of epilepsy in children. So it's estimated 1 in 50 chance of developing epilepsy in later life, just someone who is a febrile convulsion. So if you have 100 children, at least 2 of them, they may have an epilepsy, 2 of them. But it is not very 100%. Could you switch the mic? Who's talking, please? Have a one. They have it later in life. It's not related to febrile, maybe just another type of epilepsy. So children with history of complex febrile seizures have 1 in 20. So this is a complex febrile seizure. I will talk about it, why they have 1 in 20. Sometimes 1 in 30. People who have had no febrile seizures have around 1 to 2 in 100. So if you look to exactly the same as the simple febrile, so I will not say simple febrile convulsion can lead to epilepsy in a general, but think about it. So every time you will see this slide and the other 2 slides, almost every time I will talk about epilepsy, I will present these 2, 3, 4 slides. The reason we're doing that, because the classification of epilepsy or seizures keeps changing, but this is the last one. If you don't know about International League Against Epilepsy, please go and visit their website. They have quite a lot of information. And luckily, 2 years ago, I worked very hard with 2 colleagues in Libya, Shimbish and Majdi Kara, to make a Libya chapter of this International League Against Epilepsy. And we got it, and I represented Libya last year in Morocco. And there's a lot of programs, a lot of scholarship, a lot of courses, a lot of things. But unfortunately, due to the circumstances in Libya at this stage, they can't do anything in Libya. So hopefully, when the situation is improved, you will see a lot of this International League Against Epilepsy do a few courses and a few workshops in Libya as well. So this is the seizures. You can see is a focal, generalized, unknown. And then from seizures, you go to epilepsy type. It could be focal, generalized, combined, or focal unknown. And then from this, you go to the epilepsy syndromes. This is the classification. And the classification is now related to the etiology, and related to the comorbidity or prognostic of the epilepsy. So before this classification is only related to the focal generalized, and then go diabetic generalized or syndromic generalized, and focal, is it a complex or local, so, or partial. But now this is the typical. So everything in the middle, it has to be linked to the on the side, etiology and comorbidity. Comorbidity, that means the prognostic of that. So that's for the children. And now we go to there is now a neonatal seizures classification, which is in 2019. This is a framework, and exactly the same: motor, non-motor, and electrographic, and then epilepsy syndrome. So the neonatal seizures is different, completely different. When I said neonatal seizure, that is meaning the first 20 days after birth. So that is why we call it as a neonatal seizure. It's completely different from infant and children's as well. So etiology, you see HIE, which was not there in the other one, but the other is exactly the same. And then the comorbidity or the prognostic feature. So when you classify them, you put them together, the periphery. Okay. Etiology, and you can see is etiology is really the highest etiology is you can see is a genetic, really 32%. This is one of the study done in Scotland, and 27%. Third is a structural. 2 is before we think it's a metabolic before we started genetic. Genetic now is becoming really very, very common to diagnostic for the epilepsy. So we will talk about it a lot, and I will give one topic about the genetic in epilepsy as well. So next one is, so the same thing, diagnostic test for epileptic seizures. And you can see here, I'm still talking about the genetic. So this is before we know doing any blood test or any test, we can say is before that, and when take the history, taking everything, we always make assumption the cause of it, or what diagnostic test we want to do, or even this. But now the neuroimaging is if there is a structure, or if there is a child who born with HIE, or have a stroke, or have a car accident, or have encephalitis or meningitis or anything in the past, or there's a family history of syndromes or anything, then you think this is neuroimaging structure. But now you can look to all the 5 columns here. It's genetic. So the genetic test is becoming quite a lot and very helpful. We'll talk, as I said, we'll take it more about it as well. Now, classifications of seizures, if you know it, if you don't know it, is okay. I mean, I'm not going to spend time on it, but just to let you know that is focal onset, aware, impaired awareness, motor onset, non-motor onset, focal or bilateral, and the generalized motor, tonic-clonic, and then unknown onset, the same thing is unclassified. So this is the classification of the seizures. The same thing. It is a long, prolonged one, but it's still the same. This is typical of classifications of seizures. There is epilepsy is recurrent seizures. That means 1 or 2, so more than 2 epileptic seizures. So that's what we call it, epilepsy. But seizures, even ones, even febrile seizure or provoked seizure or something. So that's why I want to talk about it every time when I do one lectures about epilepsy. I will present these 4 or 5 slides. So now we are going to the provoked seizure, because febrile convulsion is one of the provoked seizures in the children. Why are we saying provoked seizure? Because seizure can be followed and treated immediately, like the hypoglycemia, like febrile convulsion, like hyponatremia, hypocalcemia. So these things is called the provoked seizures, which is there's a cause which you can treat it as well. And majority of them is a benign. They don't lead to epilepsy in the future. So that's why we're saying. So a child who's coming fitting in ER or in A&E or anything, if there is no temperature, then your first thing to do is sugar. Then, of course, you can do electrolytes. If there is a gas machine, it can give you calcium. And so that's the why I'm saying Provoked. May occur whenever the precipitating situation is present. So febrile convulsion, we know 30%. Febrile convulsion may occur in the first 5 years of life. Hypoglycemia, if you couldn't find the cause, or the something metabolic or something, or hyperinsulinemia, or if you couldn't find the cause, then it will reoccur. Every child go home, and then I'm sure a week later come back to you. So it's impossible not to send the child home until you find the cause, like hyponatremia or hypocalcemia or hypomagnesemia. So that's the don't constitute epilepsy. Population-based study indicate 25 to 30% of first seizure are acute symptomatic or provoked by brain insult or metabolic or toxic disturbance. Remember also, toxic, when we said it's toxic, it means someone who's overdosed, taking something, medicines, or try to suicide, or try to take an overdose, especially in teenagers, or sometimes even parents, they give it because non-accidental injuries as well. So think about all of these, toxic and others as well can cause provoked seizures, toxins, I mean. Now, investigation after the first febrile seizures or any seizures, we think about the blood glucose. If there is no temperature, if there is a temperature, you still do it. Blood glucose value should be checked if the child is still convulsing as well. Even if there is a temperature, you check it. You have to check it because it can be consistent together. Electrolytes. So as I said, there's a child who's coming to the A&E, fitting, have a temperature, or if they don't have a temperature, then yes, you go for hyponatremia, hypocalcemia, or other electrolytes. If they are having temperature and they're still fitting, you still need to do it. So all infant with febrile convulsions, if the baby is less than 6 months, or if history and clinical findings suggest vomiting, dehydration, or failure to return to baseline. So you have to think about it as well as a part. And I put some references there. You can go and have a check them. And hopefully this talk will be on the record and you can watch it again and review this. The same thing, even these papers written in the 90s, if someone go and do something now, the figures has not been changed. It's still the same. So 7/65 electrolyte problem, 4 they have hyponatremia, and 3 have hypocalcemia. So it is very significant. So toxicology screen is no much evidence, but recommendation is any question drug exposure or substance abuse in pediatric age group, you should do it. It's one of the provoked seizure. Even if the child is still temperature and seizure is not controlled, and he came back 3 to 4 days later without a temperature, then you think about it as well. So I think the history and examination will guide you to where you're going. Okay. The big questions here for the children who have a febrile convulsions is the lumbar punctures. I think the jumping and doing a lumbar puncture in a child who's unwell and he still has seizure and he couldn't get to the bottom of the tooth will not change the course of the management. If you think the child have encephalitis, have a meningitis, or anything else, then I think the lumbar puncture can be postponed the next day or even 2 days because the evidence will not go away. Especially now we have the PCR, which is a DNA marker for the bacteria or the viruses or something. So if the child is not well, don't jump and do LP. I think leave it until the child is settled. You happy? There is the child is. Then you could convince parents, and you could do the LP if you want to do it. It is these days we have the PCR and DNA analysis it can be done at any time because the bacteria or the virus marker or footprint will stay in the fluid for a longer time. And also the child will be much better, have an antibiotic, have the fluid, have the seizure stopped, and it's much better. So to avoid risking of herniations and then the child will be really in a bad state. And you can see here, right there, the LB is in children 2 months to 24 months of age. 12% had white cell C proteins high. So it's so recommendation in very young, below 6 months. But as I said, always think about the clinical before you're doing LB. In a child of any age with persistent alteration of mental status, even if the child is, remember that CT scan or MRI scan will not help you quite a lot because it will not show cerebral edema and everything, so to prevent, or any child with sign of meningitis or encephalitis, but you can postpone it for 24 hours or 2 days. Otherwise, LB is of limited value in first febrile, especially in a first febrile seizure. There's no limit. There's no space for the LB. So febrile, yes, but postpone it maybe 24 or 48 hours. Neuroimaging and EEG in febrile convulsion? No, there's no evidence of neuroimaging to be done in febrile convulsion unless there is a focal child who have a meningitis or encephalitis. Yes, you may want to do it, but not for someone who's have a febrile seizure and then after 3 minutes or 5 minutes he's perfect or his temperature came down is okay. EEG, I think EEG is a lot of people they requested, especially on the pressure from the parents. But I think when you have someone who had a focal, like focal seizures with the febrile convulsions, it could be one of these encephalopathics or syndromes of encephalopathies, which I will talk about it shortly. But otherwise, there is nothing. And always there's something will come and EEG said, oh, slowness on the background, slow. It is not epilepsy. I will not dream to diagnose as epilepsy in these children. So it is not only indicated if there is a focal or if the child had like have a vaccinations and 2 or 3 days later had a temperature and had his first seizure. Think about it because of the Dravet syndrome. Also, child who's 9 months old, who's have a febrile, have an illness, and then he developed prolonged seizures. Think about Ohtahara syndrome. Think about infantile myoclonic epilepsies, or other encephalopathies. So that is EEG where you can think about it. So. But not to order it in simple febrile convulsions. It doesn't make any difference, but you're under a lot of pressure, and then you will find some slow, sharp waves in the EEG, and you tell parents, and some people, I find it a lot, they treat this. It is not, never treat EEG. We'll talk about it when we talk about EEG. So criteria for hospital admissions, child with the febrile convulsion, so under the age of 1 year, because specifically if the parents really very anxious and also you couldn't find the focus of the infection, or Glasgow-Coma scale below 15, like 12 or below, or AVAPU is abnormal, meningism or sign of raised intracranial pressure, we'll talk about it, and very unwell, sign of respiratory aspiration after the seizure, hyperparental or carrier anxiety, or complex febrile seizure. When I said complex febrile seizure, it doesn't mean prolonged, focal, loss of consciousness for longer time. So that is all recurrent, one after the other. Then they have one, and after 5-10 minutes have another one and another one. So that's the criteria for, and the sign is in international, it is in Scottish International League for Epilepsy. They have this criteria. So maybe in your hospital have a different criteria, you can adopt them, you can use this one or design yours, but as long as don't overdo it. Now, what is simple and what a complex febrile convulsion? This is what I'm going to see. Simple is 70% of the febrile convulsions that's happening. Complex is 30% of all the febrile convulsions. And remember, febrile convulsions happen in the first 5 years of life. It very rarely happen after the 5 years of life. The recurrence rate is 30% for all the febrile convulsions. And there's no, they said it slightly affect more boys than girls. And the and the first year of life is the worst one. It's also familial in 17%, and it is very rarely after the age of 5 years. So the simple febrile convulsions here, or what we call as a simple or benign, is self-limited. One, according to the classifications, is generalized tonic-clonic seizures, less than 10 minutes in duration. Some say 15 minutes, but it's very rare. It's usually these days, if it's more than 5 minutes, we classify it as a status. No recurrence within the 24 hours or within the same febrile illness. So that doesn't mean they have one and they don't have 2 or 3. That's a simple one. For this simple 70%, the risk of epilepsy, like for normal population, 1 or 2 per 100 people. So it is not, it's a benign or self-limited type of non-epileptic provoked seizures. So that's the simple. The complex one is different. So the complex is a 30%. So focal features in 16%. Sometimes it lasts more than 10 minutes, or they go in a status epilepticus. One of the commonest causes of the status epilepticus in children, or prolonged seizure in children, is a febrile convulsions. So it's about 8%, and 2 or more within 24 hours or within the same febrile illnesses. So this is the percentage of the that can happen. And this complex complex febrile convulsion, this is one which may cause epilepsy in the future. So 1 in 20 or 1 in 30. So this is where you're going to talk to the parents. If you are pediatricians or someone who work in A&E, or you are a student in pediatric, this is knowledge is very good for you. So this is where you go to talk to the parents and telling them about it, and about what is the consequences of febrile convulsions. So developmental epileptic encephalopathies, which they are usually precipitated by fever or first febrile convulsions. This is early infantile developmental. This is used to call infantile myoclonic epilepsy, or Otohara. The other one is called Otohara syndrome. All of these it is usually what they have. These children, they are, some of them, normal development, and then suddenly, 3, 4 months, 6 months of age, they have a fever, or they have a vaccine and they have a fever, and they develop epilepsy, which could be focal, could be myoclonic, could be generalized tonic-clonic, and the people they diagnose them, and so these children need attention, especially if they're becoming recurrent. And they will becoming recurrent, and usually by the age of 2 years, you will see they are really very developmentally delayed if you don't do anything about it. And they have a genetic test on this as well. Dravet syndrome is one of these syndromes which happen in the first year of life, and usually precipitated by fever, and it can actually happen at the age of 4 years as well. And usually people before, when they give whooping cough vaccine, and the children develop this encephalopathies, and they have this seizures. So the people said, "Oh, whooping cough vaccine causing the this epilepsy," but no, they have no relation whatsoever to epilepsy, and it's not causing of this. And later on, in the 90s, they discovered the gene, and they proved to people this is whooping cough vaccine. It doesn't cause epilepsy. We will talk about it later, so how to treat some syndromes. Infantile spasm, you know it. Hopefully you have you can read about it, and we will talk about it as well in epilepsy syndrome. And then you have epilepsy of infancy with migrating focal seizure. This is another one, which is they usually start at the age of 2 to 3 months with provoked by temperature, but they have a hemimyoclonic epilepsy, one after the others, and then this is a benign. They grow out of it and will not cause a problem in the long term. So can you mention, I'm going to touch on the meningitis. Can you mention 3 signs and 3 symptoms of meningitis in children? This is a question for you. I just want you to write down 3 signs, 3 symptoms. And then we will Just give you maybe 10 seconds, yeah? Okay, so if you wrote them down, here are the answers. Can you mention 3 signs and 3 symptoms of meningitis? So fever. Yeah, first, yeah. Could be vomit, headaches, or sleepy. Sometimes light is hurting as well. Signs, rashes. This, yeah, confusion or seizures or the slight light. So this is the other one. This is the other for someone who's younger, babies and toddlers, and then children and adults. And this, I think the internet full of these things, and you can see sign and symptoms and a meningitis. There is a difference between meningitis and septicemia. So because when you have a meningitis, it could be meningococcemia or Neisseria meningitidis or pneumococcus or other bacteria. So that's what causing it will. So the symptom, they are integrated with each other. So you can't separate meningitis and septicemia sign in children who are having this. But think about it, because the meningitic sign could be start before the septicemia. So septicemia, it could be the second phase of the meningitis. So if you don't recognize it and you don't treat it, the child goes to septicemia and then go to shock. And the shock, really, as we said last time in recognized sick children, then if you don't recognize them in compensatory phase, then you go in uncompensatory phase, and then sometimes you will lose them. So that's why is so the meningitis sign, it is usually recognizable, hopefully, by doctors, and more hopefully is by parents. If you teach parents, if you design a leaflet for parents to recognize the meningitis sign, then hopefully they will not go to septicemia, and then they go to their morbidity and mortality will increase. So another task for you, so to design probably how to recognize meningitis sign leaflet for your patient, for your friends, for your colleague, for your hospital, and then share it with others. So this is another task, hopefully. I don't know if some of you have draw a chart from the previous lectures. We said about recognized sick children. If you draw any chart, please, if you want to share it, I'm quite happy to share it with you. Before and after meningitis B, because I know there is meningitis C, there is a vaccine, the AW1C, there is a vaccine, pneumococcus, Haemophilus influenza. This is the commonest, can cause meningitis, devastating meningitis. But B, it is only being used in the last 2 years in North America and in Europe. I don't know, Libya, very unlikely to have it. And this is meningitis B, or Neisseria meningitidis type B, is the one of the now the leading cause of the meningococcemia, or which lead to sepsis and meningitis and deaths. So the vaccine, since we start using it here in UK over the last years, I haven't seen a single case. We used to see between 200 to 300. So it's another lobby to hopefully to Libyan to get this vaccine as soon as possible to children. How to tell parents to test for Febrile crashes? Can you write it down? This is another quiz for you. If you can write it down, and there's many ways. And I just want to see, and I will mention one which is simple. You can it can be done at home very easily. Just hold the glass, very transparent glass on the rash. If it disappear, it is not Febrile crash. And it is not Neisseria meningitidis or pneumococcus or Haemophilus influenza, or which lead to meningococcemia and meningitis, meningococcemia and septicemia. The other thing sometimes is you can pressurize it with your finger and press on it, and if it disappear, it is not Febrile crash. It's not so it is not one of them. And this is other things which you could include in your leaflet or in your pictures on the ward or in the A&E, so the parents, they can see it. Or if you have a program on a TV, you can do the same thing and show to people how to do it. It is It's just delivering information to the parents is very, very important, because this is the people who are with the children at home. If they don't recognize it and they bring the child to you in compensatory phase, then they bring the child in uncompensatory phase. It's too late. So that is why it's another thing. I know it's a public health, they should do that, but also as a doctors, you should also have a responsibility to do this information to the parents. Now, so I finished my first bits. Now, we next 10 minutes or 15 minutes, we're going to go a case. There is a case about febrile convulsions, and then read this. Is a 2-year-old girl called Becky is brought to her local emergency department with the following history. Her mother had left her in the living room to prepare her meal when she heard a scream. She rushed back to the living room, and in her own words, her lips were blue and she was stiff all over. Her eyes were rolled upward and her breathing was shallow. I went to pick her up and she began to shake all over. So that's the mom story, what she's telling you when you took about 10 seconds to take the story. So that's the case. So what do you think here? Just think about what will be the cause. Okay, if you write it down. So the episode lasted 15 minutes, and afterwards she was drowsy and fell asleep. Her temperature was 37.5. She had a 12-hour history of runny nose and fever. Her mother had run out of the Calpol and ibuprofen. Calpol is a paracetamol we call it here in UK, and ibuprofen is ibuprofen. And Becky had not had any antibiotics for the last 24 hours. And her mother had stripped her clothes off, opened the window, and put a fan beside her. So I want to say, is this febrile convulsions? I just want to say yes or no. Is it right, the mom, to put the fan and strip her clothes and open the windows, even it's winter here, below 0 temperatures? And the other thing, what she should do. So this is the 3 questions. So now, she had a similar episode. All these questions, I want you to think about them, then we will answer them together. Yeah. 11 months, her maternal grandmother is known to have epilepsy, or epileptic seizures. Diagnosed at 3 years, her mother also suffered with febrile convulsion as a child. So the clues here, so for you all of this, what type of event do you think this is? I hope you write febrile convulsion, yeah. What else is the differential diagnosis for children with febrile episodes? So what do you think is what is your differential diagnosis here? Could be because of a febrile episode. So the first thing is you're looking for evidence of infection. Where is the source of the infection? Is it viral? Is it bacterial? Is something else? What type of event? Yes, is it febrile convulsions? Is it simple? Is it benign? Yeah. Okay. Question 2. Was this simple or complex febrile seizures? Remember, I gave you the slide for complex. Early and complex. Okay, here is the slide again. Yeah, so this is simple 1 or benign. According to new classification, they call self-limited. We know it's a provoked and it doesn't yield to cause epilepsy, but there is a risk is about 30%. While complex is the same, it can recurrence is 30% in the next until the age of 5 years, and also can 1 in 30 or 1 in 20 they will have a risk of epilepsy in their life, and it is not simple. It is not self-limited in the future. Okay, question 3. Is the temperature 37.5 high enough to cause febrile seizures? I know there will be a lot, just want your thought about it. There are 3 answers here. So we just want your thought about this. This is because sometimes this is what you're going to talk to the parents. They tell you, oh, it is 37.5. Shall I give Calpol, paracetamol, or shall I ignore it or something? Yes, 37.5, it's not a temperature. It's not a high temperature, I would say. It is likely to be peripheral temperature. Fans, tepid sponging, etc. may increase core temperature. So if it's 37.5 and the child known to have 3 or 4 febrile convulsions in the past, then tell parents to start giving the Calpol or the paracetamol, because this temperature go up. Because, you know, in febrile seizure or febrile convulsion, the temperature, it doesn't go in a steady, it go like sharp up. When it goes sharp high, that's when causing the seizures. But if you teach the parents to give the paracetamol and or ibuprofen every 6 hours, so that means keeping the temperature on low threshold all the time, so they won't have this peak sudden raised temperature, so they won't have another febrile convulsion. And in the same time, if the temperature is, of course, if the temperature is 39, 40, they need to go and see someone as well. They don't stay at home. Remember that we said early, fan tepid sponging may increase core temperature. You remember that is the pores of the skins. If you direct the fan to the skin, you know we have this small muscle, and these pores of the skin will collapse and also will not allow the temperature to go outside the body, because when the sweating and that's where the temperature go out. But if you do fans or tepid sponging, the pores of the skin will be closed and the temperature will stay inside, and the core temperature will go high and make it worse. So never put the children in a cold water or put them in ice cold water or fan. So maybe the best thing is if ibuprofen or Calpol, cold sponging. If they don't take it per mouth, then you give the paracetamol through suppositories or through rectum. And also we know that is diclofenac sodium, there is a suppositories as well, but not to overdo it. Significant core temperature often needs to be assumed rather than proven. So because sometimes you have to assume this is a high temperature. Okay, question 4. Criteria for hospital admission. We said it early. Will this child will be admitted to hospital? Yeah, yes, I think we did it, because 1 year, confused, unwell, we don't know what's the cause of the temperature. So this is the same thing again. So this is a criteria. It's not necessary to be 100%, but maybe you have your guidelines, or maybe if you're not sure, then ask your senior about these children, because any child who came with a febrile convulsion, hit the A&E or oxygen emergency, make sure you find the focus of the infection before sending them home. Okay. Question 5. Becky's mother asks you, is this going to carry on? Why can't you just start her on medication? That means anti-epileptic drugs. If you see any one of your colleagues, senior or junior, starting a child on anti-epileptic drugs following first, second, third febrile seizures, please stop them. There is no evidence this will work. You're just drugging the children for no reason. So what is your response here? You say, yes, I will start her on anti-epileptic drug. Yes, I will give you this, I will give you that. So the question is here. So the risk for further febrile seizures, so you give them the risks here, you see. Overall risk is 30%. Remember the number of the risks here. So the number of the risks here, I mean, if risk of recurrence is 15%. This is the 3 risks: early age, below 18 months, family history, febrile seizure, low temperature, below 40, complex feature is not a risk. So if there is only one risk, so the risk of recurrence is 27%. If there are 2 risks from these 3 risks, then the risk is about 40%. If there are the 3 of them, then it's about 65%. So when you're speaking to the families and they ask you whether it will happen again, so remember, this is the risks. This is the 3 risks. And then you can tell them, this is an evidence-based. So you can tell them with confidence, that is the risks. You can give them, people like figures, people like confident doctors tell them the really evidence-based as well. I don't know, in Libya, I know every human being, they understand what does that mean, 15% or 27 or whatever, whatever way you can tell them about it. The mother then asks you again, will she develop epilepsy? What is your response? As we said, there's simple, self-limited one, there's no risk. Complex, there's maybe 1 in 20 or 1 in 30 risks, yeah? So the same thing again. So here's the risk of epilepsy. As again, you can talk with a very confidence, overall is about 3% develop epilepsy. So 3 in 100, they may develop epilepsy, but risk factor, abnormal neurology prior to febrile seizure, they have a brain damage, need developmental delay, metabolic, or anything. Family history of febrile seizure, the family history of epilepsy, especially starting in childhood, or complex febrile seizures, as we said earlier. If epilepsy does develop, it can take many different forms. So if there's 0 risk from these 3, 1%. If there are 1 from these 3, there's 2%. If they are 2 or more, then the risk 10%. So this is you can say this with confidence when you talk about the febrile convulsions risk of epilepsy to the for families. So this is a course which we deliver in UK a lot, and we teach a lot of pediatricians, a lot of people who are training in neurology, and we give them exactly the same information as you. So hopefully I'm now just another 2-3 minutes, please. What advice would you give parents prior to discharge? So I think before sending them home, and if you find folks of the infections, antibiotic advice, although may not influence likelihood of seizures, seizure first aid advice, and consider rescue medication if prolonged. When I say rescue medications, we will talk about it when we manage status epilepticus and how to manage status epilepticus. A lot of people now, if the first seizure benign, less than 3 minutes, and you find folks of the infection, you can guarantee you send them home without any problem. If they have a prolonged seizure more than 5 minutes or recurrent febrile convulsion, you may consider rescue medication. When we say the rescue medications, there is 2 types, either rectal diazepam or buccal midazolam. But the buccal midazolam, it is much better, much benign, have no risk factor and easy to give. But for rectal one, we are avoiding it at this stage, except in someone who under the age of a year may be given. So we'll talk about it when we talk about the management of status epilepticus more, which one you will give. But please don't send the children who came with the febrile convulsion, first one, not prolonged, and you found the folks of infection, send them home with the buccal midazolam or rectal diazepam, because I know people, they want it and people, they heard about it, but I try to define and teach your colleague not to. About the antibiotics, yes, you can give antibiotics, paracetamol or ibuprofen. You can give them every 3 hours for the first 24 hours to keep the temperature down to stop the seizures, but sometimes you can't do much about it. And seizures, and also if you have a chance, or you have a good doctors, or you want to make even much better, then show them the video of the first aid, what they do. If the child have a seizure, they put them on the right side, and then in recovery positions, don't put your finger inside there, don't do anything, just let the seizure finish. If it doesn't finish within 5 minutes, then either call the ambulance or take them to the hospital with someone who can drive the car with you or something like this. I know in Libya, we don't have this 999 or 111 or 222, call the ambulance, but I think you can improvise. Or show them the video. If they stop breathing, then do the basic life support video for them. It is not something, this is educational for them. They will feel they know what to do if something happens in future. So seizures also, there is a compensatory phase and the uncompensatory phase, which we spoke about it last time, and I'm going to talk about it again. So make sure you treat this patient before they get into uncompensatory phase. So if they go on a compensatory phase, it is difficult to avoid the morbidity or mortality in this group. And I will talk about managing the children with the prolonged seizures in next lecture. So in summary, febrile seizures are the commonest type of provoked epileptic seizure encountered in children. They are usually benign or self-limited. Most children with febrile seizure do not develop recurrent non-febrile seizure epilepsy, although the risk of epilepsy is increased. So that's what is the summary, and hopefully that is summarize my objective as well, which we started at the beginning. I hope I achieved the objective. And any questions? The questions is, okay, let me close the, stop the sharing, and then I will look to all the question, the chat here. Okay.